Welcome to the Spring Research Symposium of CNTN. My name is Hans Vorster, and I am together with my colleague Karthik Tennankore. We are hosting today's meeting. We are both co-chairs of the executive committee and co-leads on the research operations committee. So Karthik and I spend a reasonable amount of time together. It's as I said, we are your co-hosts, and we are. I'm speaking to you today from Kingston, which is where I'm from, and which is in the territory of Kataraqui, which is the traditional land of the Anishinaabe, Haudenosaunee, and Wendat people, Huron-Wendat people, who have lived and taken care of this territory for thousands of years. And I also acknowledge the traditional lands that you are all representing by attending here today. I think that's all I can say this for now. I'll pass it on to Karthik to introduce the actual program.
That's great. Thanks a lot, Hans. And, really excited to be here. And, I sort of second everything that Hans said. I do want to quickly thank the CSN for providing the infrastructure for us to present today. And I'd also like to thank CANSOL for all of its support of the CNTN. I know that CNTN is really a part of CANSOL, and we thank them for everything. So what I wanted to start off today with, along with Hans, is just give you a little bit of an update of where we have been since March 2020. And for those of you that remember March 2020, it really has dictated the last couple of years with, of course, the pandemic. But I have to say that it's always pretty optimistic to say that we managed to weather the storm in a lot of ways and maintain a lot of work together as the CNTN group to try to pivot and do the best we could as an organization to really keep the momentum up for what we were trying to do. So since about March 2020, we were successfully able to peer review 5 proposals. And just to clarify what that means a detailed overview of 5 proposals with a scientific review, patient review, with the ultimate goal of providing endorsement after, really providing comments back to the proposal writer that are a way of trying to get their proposal in a better state so that they can get, higher level funding, provincial funding, national funding, or other. And really, we hold ourselves to a very high standard with these reviews. We aim to maintain a lot of scientific integrity, and we really do our best to provide detailed feedback. And so I was happy to say that of the 5 proposals that we did do peer review for, 3 of them were ultimately endorsed. We were also successful in writing 22 letters of support. This is more of an abbreviated version of support, whereby we provide a letter in the context of sort of grant funding opportunities, just saying what the CNTN can provide and can do. And then we were able to host 2 virtual research symposia. We had 6 proposals that were presented at these, and we even had an invited speaker talking about some trials and tribulations with clinical trials. That was on the scientific review side, but we did a bunch of other things with our other committee arms. Started a podcast. We have a new CNTN Spotlight. These spotlights are there to share results of research, new studies, publications, lessons learned, and stories about how we're doing our best to maintain patient engagement. And we've had about 5 of these episodes released, and I think they've been really met with a lot of positive opinion. We've also really increased our, what I would call our Twitter base. We've grown our Twitter followers from around 110 to 373. And we've increased our newsletter subscribers from around 285 to 311. So I think we're starting to really connect the Canadian community a little bit more. Next slide. Really importantly, we've had some excellent feedback and participation from a number of committee members. Nancy Verdon is a patient partner who joined us from Red Deer, and she's now a member of our scientific operations committee. And I've had the opportunity to hear a lot of her excellent feedback on some of the proposals. And I find I'm always learning something new from Nancy, to be honest. Dr. Cal Robinson is a nephrology trainee who's joining us and is currently at Sick Kids Hospital in Toronto. Dr. Michelle Wong, a nephrologist at St. Paul's Hospital in Vancouver, and Selena Alou, whom we all know probably pretty well, CANSOLVE-CKD knowledge translation broker from Calgary, also joining our CEC committee. And, this is just the start. I have to say that recently there have been a number of trainees who have approached me really wanting to learn how they can get more involved in the CNTN and potentially participate. And ultimately, this is what we want to see. We want to have the opportunity to engage trainees earlier on so that they can sort of form the next future iterations of the CNTN. Next slide. And we have a number of plans for 2022. We really want to conduct a community research forum to better understand how to support community locations, community facilities, and research. This is something that has always been of importance to us, and we want to do the best we can to include the community. As mentioned, we do want to continue to increase our engagement with trainees, potentially looking at partnerships, be them formal or informal, with other groups and organizations, including things like Crescent. We do want to develop a program along with CANSOLVE-CKD to help patients speak to other patients about participating in research, sort of a research ambassador type program. Of course, we want to continue to conduct peer review and do the best we can to offer post-review supports, even for those studies and projects that we're writing letters of support with. We really want to provide our resources in a more constructive way after those grants are reviewed. We do want to develop a patient partner peer review training webinar. And we want to continue to expand our network membership to include more community-based nephrologists and other allied health professionals who are doing research, be it either prospective observational studies or clinical trials. And one thing that I'm really excited about is we are going to be playing a role in participating in the Gardner's Grove event. This is something that Dr. Amit Garg puts together, really with a focus on looking at proposals that might be suited for pragmatic randomized controlled trials, using some novel methodology that not all of us are familiar with. And we're happy that he's asked us to participate in this in a little bit more of an integrated kind of way. Next slide. So how can you get involved? Well, as I mentioned before, we have 3 different committee arms, each of which does a different aspect or part of what we're trying to achieve with the CNTN. Those include the capacity building committee, really focused on increasing the number of people and resources available to help do and perform clinical trials. And I would even add their observational studies as well. We have the communications and engagement committee. This is to increase the exposure of the CNTN to the nephrology community and try to increase our membership and participation. And then, of course, the one that Hans and I serve more directly on, Scientific Operations Committee, really focused on increasing the quality of research proposals that are submitted for funding in an effort to really enhance funding for these proposals and also provide some ongoing support to those researchers who are submitting proposals. Next slide. And we have a very busy and interesting agenda today, and I'm excited to say we chose this agenda mainly to highlight some of those individuals who have either played an integral role in the CNTN and or both, I should say, have received some support from us in a more comprehensive way, and really excited to hear what they have to say about the status of their studies. So I think I'm passing it on, I believe, to Hans for the first introduction. Is that right?
First up is, as I said, is David. And he is a nephrologist at the University of Alberta Hospital and an assistant professor at the University of Alberta. He has a PhD in health research methodology from McMaster and is interested in clinical trials with uremic symptoms in patients with kidney disease. And he's also a member of CNTN Scientific Operations Committee and Executive Committee. So David, it's over to you.
Thanks so much, Hans. Before I get started, I just want to acknowledge I'm in Treaty 6 territory in Edmonton as well. So I'm going to be talking to you about DISCO-POT, which stands for DIalysis Symptom COntrol Pruritis Outcome Trial that we've been working on for the last 2 years. So I don't know if anyone remembers me presenting this a couple of years ago. But this was initially a project that's was discussed at the CNTN at one of the meetings, and then has evolved subsequently over feedback from CNTN, from collaborators, from Health Canada, et cetera, et cetera. So it's gone a couple iterations, and just giving this opportunity to provide an update. We can go to the next slide. So this was the original trial design. So it was in adults above the age of 18 on in-center hemodialysis 3 times weekly for 90 days, having generalized pruritis with a severity of 50 millimeters. Essentially, every single one of those inclusion criteria have evolved over time. The exclusion criteria are pretty similar. So the original design, which we submitted to granting agencies and feedback from the CNTN, used a run-in period. It had the agent or investigational product was oral cannabidiol, and it was actually an N of 1 trial. So that means that there was a series of crossovers repeated multiple times within patients. So they got exposed to multiple treatments over multiple times, which increases the power to detect clinically important differences between treatments. So it looked at combination therapy, looking at oral and topical cannabinoids, and one of them was cannabidiol, and then another one was a different type of endocannabinoid called PA or AEA that was available over the prescribed in current standard of care. So the focus was initially a feasibility trial, and this is the way that we gave it towards CHR, and then it evolved over time. So we'll move to the next slide, please. Also, there was a whole bunch of stuff that we were initially going to collect. Just at the bottom there's a whole bunch of patient-reported outcome measures related to itch, sleep, quality of life, symptoms, a whole bunch of stuff that's also evolved over time. So this is the initial pitch that I'm going to show you the update in a second. Next slide, please. So we were lucky enough to get really detailed reviewed from the CNTN, from the Scientific Operations Committee, and our initial design did get a letter of endorsement that was used to apply to funding bodies, specifically CHR. That was from February 2019. So with feedback from the CNTN, as well as CENTRAL-CKD collaborators, patient partners, et cetera, we thought we were in a pretty good shape to get funding. We can move to the next slide, please. And this is some comments that our patient partners provided in letters of support, which I think is relevant given the nature of how we actually got funding through CHR. So I just want to read some of these out loud. So pruritis is one of those nasty experiences that interest me, and it is a research priority for patients. The condition is maddening and very difficult to manage, as it feels like it is bone deep, and superficial scratching just does not relieve the intense sensation. Few effective therapies exist, and even with their use, itching remains uncontrolled in a lot of patients. New therapies are desperately needed for this condition. Myself and 2 patient partners have been involved with the trial's design, including methodology, selection of the intervention, and outcomes, in addition to knowledge translation. So this was back in 2019. Having been at CHR for a couple of years now, these patient partner involvement and letters of support is kind of the move towards. In CENTRAL-CKD, we're obviously leading strategy for patient-oriented research across Canada. So this is one of the examples of why I think we were successful in funding. We move to the next slide, please. So this is our journey through CHR. So a couple submissions in spring, fall of 2019, as well as 2020. So the initial design, which we had letters of support from CNTN looking at oral CBD and PA and EA, it scored incredibly poor. That was after it was reviewed by all 3 reviewers favorably, but when it was reviewed the scientific officers, it got significantly downgraded because we didn't specify where we would get the investigational product. And this has kind of been a journey about how to do cannabinoid research in Canada. There's barriers to obtaining good manufacturing practices in investigational products. So even though cannabis is legalized, you can buy it at the corner store in different types of formulations and different types of routes. You need standardized GMP compliant investigational product, which is a huge barrier. So there's a lot of trials at that time at CHR that actually got funded and were not feasible because they couldn't navigate the regulatory perspective. So that was the feedback that killed it. We came back at them and tried having a letter of support from an investigational product source with evidence of partners that had regulatory approval, and they didn't buy it. So that was in 2019 in the fall. And then spring, we resubmitted and we switched to using nabilone, which is a synthetic form of cannabis that's THC specifically, that there is a product monograph. It was a lot easier to get regulatory approval. So at that point, I got pretty good funding, but it was still criticized for having not enough evidence to undergo trial, despite really solid reviews about biologic rationale before. So kind of all over the place. But ultimately, we were really lucky and fortunate that was selected in a project grant priority announcement for patient-oriented research. And I think given the nature how the grant was written with the patient input, the letters of support from CNTN, CNTN, that was its path towards funding, which we're happy about. Next slide, please. So also just in the background of this problem, one of the things we actually pivoted for one round of submission was doing a pharmacokinetic study of cannabinoids to gain familiarity with dosing as well as regulatory experience. And this is just a single dose pharmacokinetic study that we applied for in the interim during one of the project cycles, and it got totally torched at panel C as well for a whole bunch of other reasons. But luckily, this is actually funded through the Center for Medicinal Cannabis Research and is we're about to start it as well soon. So just a different way to approach getting funding. So this didn't work. So we can move to the next slide, please. So what does it actually look like now? So with the challenge of the budget was dropped from around 300,000 to 100,000, we've really had to simplify the design and the selection of outcomes and try to make it more pragmatic. So it's no longer a series of N of 1 trials, it's just a single crossover trial now. So there's basically, in the inclusion eligibility criteria, the changes are the age is now above 25. It's expanded to not only just in-center dialysis, but also home hemodialysis and peritoneal dialysis. The severity of pruritis was dropped from 50 to 40 millimeters, and the exclusion criteria have been expanded a little bit based on Health Canada feedback. There's no longer a run-in period. You go straight into randomization. It uses oral nabilone, so 0.5 once a day at night for the first week, and then titrated up to 0.5 BID. So that's for a period of 4 weeks with a 2-week crossover or 2-week washout period in between the crossovers, and then another 4 weeks of the second crossover period. So it's a total of about 10 weeks. Currently, it has regulatory approval through Health Canada. It has ethics and contracts in Winnipeg and Edmonton, so the 2 sites. The sample size is now 12. It's no longer a pilot feasibility trial, it's a full trial, which we capitalized on repeated measure and a crossover design. So we're just waiting on investigational product, which is supposed to be manufactured this month after lots and lots of delays about actually sourcing the nabilone, which is really hard to get in Canada. Next slide, please. So this is the whole list of the inclusion-exclusion criteria. I won't go over them in detail, but some things just to highlight is through Health Canada feedback, the age of eligibility was increased from 18 to 25 years. That's because of the potential negative effects of cannabinoids on cognitive development in people under the age of 25. There's some safety thresholds about liver function and liver enzymes based on the nature of nabilone and the product monograph and dosing. And then as well, there's some other exclusion criteria related to sex and gender, as well as psychiatric illness and intradialytic hypotension that are in the product monograph. So feedback from Health Canada that needed to change things. Next slide, please. So still a lot of patient-reported outcome measures. So at the bottom, you can still see that there's the visual analog scale and the verbal rating scale and numerical rating scale for itch. Also quality of life from an itch and overall perspective. We really dropped a lot of the other stuff we wanted to collect just based on feasibility and patient partner feedback, but it's basically every week during the crossover period with a window of plus or minus 3 days, safety, adherence, and efficacy are assessed. So there's a lot of repeated measures that decrease the sample size for the primary outcome of the visual analog scale. Next slide, please. So where are we at? So the investigational product actually finding nabilone. So having a letters of support for a grant saying that one company will provide it for you, when it actually goes about actually getting from that company, I've learned that there's no promises. So we initially were supposed to get it through Barrel, which I've previously done another trial with. Then we pivoted towards PCI, no luck. Then Hamilton Health Sciences, no luck. Tried a whole bunch of ones. So this has actually been a 3 to 6 month delay. And finally, we settled on TIPT in Toronto. So still waiting for it to actually be manufactured, but to get availability and to sign a contract with, there's a lot of delays. From a Health Canada perspective, this was another 3-month process back and forth about changes to eligibility, about adding dose titration, even addressing things like driving, which we hadn't really considered in detail, which was relevant because a lot of patients that are healthy and engaged to participate in trials can drive to dialysis. Then there's controlled substances approvals. That's had other delays from January to March. But finally, we're able to navigate all of this and have ethics and site activations. So we're hoping for our first patient first visit this month. Next slide. So unfortunately, we haven't actually started the trial and I don't have any results to share with anyone or any baseline table 1, but I think there's some valuable lessons learned navigating through this process as a new investigator that's embedded within the nephrology community in Canada. So I think the first thing is just for my own learning as a new investigator is don't give up on a good idea. If there's interest, it's a patient-reported outcome and it's a patient and clinician priority. So don't get disheartened about disappointing reviews, or if there's any identified fatal flaws, you can always come up with a solution to come around it. And it's obviously going to take multiple attempts to get funding. Next one is patient partners can really make a difference. So I've been lucky enough to be trained in ERA where this is kind of the standard of care or standard of methodology for clinical trials and research. So important that having patients with lived experience with pruritis have had input into the study design, funding applications, design of patient materials, and have plans for knowledge translation. There's lots of barriers to cannabis research in Canada, but over 2 years, there's been some significant progress. So this is one trial that has Health Canada approval, and our pharmacokinetic study also has Health Canada approval. Always have a backup plan and another backup plan for investigational product, because sometimes companies say they can do things, but they can't necessarily do it. And lastly, don't be afraid to challenge Health Canada on some of their decisions. I think gaining confidence about what is reasonable and not reasonable for a pragmatic trial design. And lastly, just as a sidebar, changing institutions in the middle of a grant generally will slow down trajectory. So that's another valuable lesson learned. So I'll stop there and I'll take some questions if there's any.
That's great. David, thanks a lot. I'll just start maybe by seeing if there's any questions or anyone have any comments. A couple of different ways just to remember, you can type your question out or, certainly if you want to raise your hand, I'll see if I can make sure I can see everybody's contact stuff there. If not, and you just want to start talking, go ahead. Don't worry, David, I have about 15 questions I'll ask you in a second. Nothing. So I guess just a common way to persevere, David. And I think that's honestly one of the big take homes from this. It's an interesting area, obviously, that you're studying in the sense that it's kind of, it feels like it's a little bit new, although there has been exposure or use of these medications in other types of patient populations, but maybe new to the work that we've sort of been doing in the kind of kidney sphere. One thing I wanted to ask you is more, you've done a couple of different surveys at this point, as I know. Can you maybe chat a little bit on, just in the context of this area of research using cannabis type products to sort of manage symptom burden? Can you chat a little bit on some of the insights that you found from those surveys, both from a provider sense and from a patient sense in this kind of area?
So in the last 2 years, we've done patient and nephrology surveys about prescribing medicinal cannabis, use of recreational cannabis, and interest in our randomized controlled trials for symptom management. So a couple of key points to notice is, so nephrologists are broadly supportive of testing cannabinoids in the context of a randomized controlled trial with appropriate dosing and safety monitoring, because for a lot of symptoms, whether it's itch or restless legs or chronic pain, or you name it, the standard of care is limited. There's still residual symptoms. So I think there's a lot of support from a nephrologist care provider perspective. Not a lot of experience with actually prescribing cannabinoids and dosing and interactions and stuff like that. But that's the kind of the physician perspective. And that's based on about 150 nephrologists from across Canada. From a patient perspective, so we did an online survey as well as in-person recruitment. Similarly, a lot of interest and support, but it kind of depends on the symptom, and there's a hierarchy. So chronic pain and nausea and vomiting and GI symptoms have the most interest. Things like anxiety, depression, and fatigue, less interest or support. Main barriers are, number one, a lot of patients, up to 10%, are actually habitual users of cannabis and are not willing to stop their baseline use to participate in trials. So there's always that concern about contamination. And then there are a lot of patients too that just don't have an interest for specific symptoms. And there's about concerns about abuse potential, dependency, side effects, harm, cultural, religious reasons. There's a whole bunch of things that are unique to patients. So there's definitely people in the pro, there's people in the con. I think there's generally a support to do these trials moving forward, but some questions that I think we need to pursue with some qualitative work moving forward to really nail down these concerns and barriers to cannabis-related research in our population in general.
No, I think that's great. And sometimes those surveys are really important too, because I think they kind of open the eyes up a little bit with the community itself, just about being aware and understanding what some of those patient interests are for sure. I'm just going to see if there's any other questions. I have another question somewhat unrelated, but anyone else have any questions or comments? Okay, just among the lessons learned, because I think this slide's quite important, just about understanding how to embark in an area where there's a little bit of uncertainty and just learning kind of as you go. So, you sort of say, don't change institutions at the start of a grant, obviously highlighting some of the difficulties you faced, but, knowing that there are trainees on here who may be wanting to seek support for a clinical trial, who are really going to be in that transition part of their career, going from, trainee to new faculty position, and who maybe want to hit the ground running early with a trial or a study or a pilot, but will be changing institutions. Can you provide any suggestions or tips about how they might be able to navigate that period?
I think one of the challenges is, so you're gonna be starting your project or research at one institution, and the sponsor is going to stay the same. The infrastructure is generally going to stay the same. Make sure that you have a collaborator in the place where you previously worked that's going to be able to help out with some of the day-to-day operations, including recruitment and retention. I think the main challenges I faced was changing and hiring a research coordinator, getting monies transferred if it's relevant, contracts, navigating the whole new system. Just there's always going to be challenges in the delay, and just to set a realistic expectation. And then as part of your transition process is really get engaged in the research part and learn about ethics, contracts, all that type of stuff, that what's available early on. Yes, clinical is always going to be important and it's focused, but don't neglect these important things in any transition. And there's people there to help when you move to teach you these types of things, but also, where you came from, it's kind of still the headquarters that you have to have a regular contact with and engagement.
Oh, that's great.
And shout out to Nav Tangri in Winnipeg for being that person.
So looking forward to it. Remi, go ahead.
Yes, hi. So thanks, Karthik, for the invitation. So I'm going to talk about my trial, which is called CENTRAL-CKD. So the full name is Central Blood Pressure Targeting, Pragmatic Randomized Trials in Advanced Chronic Kidney Disease, and this is a pilot study. Next slide, please. So I think the first thing that we need to make sure is to know why we measure brachial cuff blood pressure. So it is a vital sign. So it's very important to measure it in every patient. And it's a way to gather information on the perfusions of vital organs. And why do we measure it on the upper arm? Well, it's the site of an artery that's really easy to access with the cuff. And it's relatively close to the aorta. But when it was initially designed, so more than 120 years ago by Rivaracci, it was designed as a way to have a surrogate for the aortic BP. So this is important to remember that. And this assumes that the blood pressure that we measure with the brachial cuff should be about the same as the blood pressure in the aorta, which is really the true way to measure the blood pressure in the body. And we know that this way works. I mean, there's decades of research and lots of trials that show that when we reduce the brachial cuff blood pressure, we improve patient outcomes. Next slide, please. But we have to know, is it accurate to do so? And the way we do it these days is we validate blood pressure cuff machines with the auscultatory manual method using the carotid cuff sounds. But we now know that the carotid cuff sounds do not really coincide with the opening of the artery. So there's a bit of a delay. So this delay tends to make an underestimation of the brachial cuff, which is the true brachial cuff, brachial BP inside the artery. So the best way to do to check accuracy is to check against invasive aortic blood pressure. So there was a meta-analysis published a few years ago now that compared what's the difference between the brachial cuff blood pressure and relatively simultaneously measured intra-aortic systolic blood pressure. And when we put all the patients together, it's relatively accurate. So just a difference of 0.3 millimeters of mercury between the two. So this looks good. But when we look at the absolute mean difference, and this is more of a reflection of individual patient level accuracy, it's much more wider. Next slide, please. So one of the main important aspects that needs to be present in someone to have an accurate brachial cuff BP reading is the systolic blood pressure amplification. So what we learn in med school and all that is that usually from more central arteries like the aorta to more distal ones like the radial, the systolic blood pressure tends to increase the further we get from the heart. And the diastolic barely moves, and the mean arterial pressure is, again, almost identical all the way through the arterial tree. So this is called systolic blood pressure amplification, and it results from the blood pressure waves moving from an elastic component of the blood pressure, the blood vessel, to a more stiffer blood vessel, how it goes along. Next slide. So with this aspect, and when we add the fact that the brachial cuff underestimate the true brachial SBP, by pure chance, the brachial cuff tends to be relatively accurate to determine the aorta. Next slide. So, but the thing is, not everyone has systolic blood pressure amplification. And when we compare the blood pressure with and without SBP amplification, we see that the patients who have the stiffest artery tend to have the greatest underestimation of the aortic blood pressure with the brachial cuff. We can go to the next slide. And there's really is no way to differentiate the patients who have or who don't have SBP amplification. It tends to have patients with the highest aortic stiffness, but it's not that simple. So it's really, we only have to do invasive studies to see if this phenomenon is present or not. So it's not predictive. Next slide. There's some indirect evidence that shows that this is accurate. So when age is increased, the more you're old, the stiffer your arteries are in general. And it's the same as your eGFR decline. So the lower the GFR, the stiffer your arteries are. So when we increase in the degree of arterial stiffness, the underestimation of the aortic SBP with the brachial cuff tends to increase. So in the oldest and the people with the most advanced CKD, The brachial cuff tends to underestimate a lot the aortic SBP. Next slide. And it's something that we're looking into with a study at Cyclica Hospital. So we're currently measuring simultaneously the aortic blood pressure and the brachial cuff blood pressure in the patients undergoing coronary angiograms. So when we look at this slide, it shows that in control subjects, so patients with no CKD, the brachial cuff is quite good to estimate the aortic SBP, but in patients with advanced CKD, there's a lot of underestimation, and it's to the degree of 1 full dose antihypertensive drugs, the difference. So it's really a major difference between the two. And this is preliminary data, but we have a bit more patient and it tends to follow the same pattern. And so if you want more details, we'll present this data in the CSN meeting later this week. Next slide. So is there a way to increase this accuracy? So when we look at all these waveforms, they all have the same systolic blood pressure, they all have the same diastolic blood pressure and the same mean arterial blood pressure, but they're not the same. They're not the same patients. So it really depends how the forward and the backward waves reflects and is additive to determine the systolic blood pressure. So we can take these waves, or we can, let's get to the next. We can take these waves, capture them with pulse wave analysis. We transform these waves and we can get what is called central blood pressure. So non-invasive central blood pressure, which is designed to accurately represent the aortic blood pressure. So this is what is central blood pressure. Next slide. And there's a lot of studies with central BP. And for now, we know a few things. Well, central BP is excellent to determine the aortic blood pressure, especially the newer devices, which are called type 2 devices. They have a better association with end organ damage than brachial cuff BP. They're highly predictive of major adverse cardiovascular events and mortality, and that's independently of brachial cuff BP. And we know that certain antihypertensive drugs, they act differently on central and brachial BP. So it's really not something that is too closely related to brachial cuff pressure to mean that we can't act on one without the other one. But at this point, there's really no interventional studies that show if it's better than brachial cuff BP. Next slide. So, and it's again something that we're looking into. So we compared 2 central BP devices, the mobilograph and the watch BP. And what we can see with these devices is that in advanced CKD patients, they're highly accurate to determine the aortic BP. And so the first number is the accuracy, and the second number is the plus or minus is the precision. So the accuracy is for the mean on the population, and the precision is for most on the individual level. So we see that the best way to estimate the aortic BP, or systolic blood pressure in that case, in advanced CKD patients would be with a device such as the watch BP central office device, much more so than the standard brachial cuff. Next slide. So what we know is that it's really the aortic BP that drives prognosis. The brachial cuff is an imperfect surrogate of aortic BP, especially in conditions with elevated aortic stiffness, such as CKD, where the brachial cuff really underestimates the aortic SBP, and the central blood pressure is really accurate. So the question is, can we use this information to go a bit further and to find something that would be beneficial for advanced CKD patients? Next slide. So this brings us to the central CKD study. So like Karthik said, it's been fully reviewed by the CNTN, then endorsed. And we were lucky enough to get funding from the Kidney Foundation last year. And we'll hopefully get a bit more funding this round in CIHR to get a bit more centers and do a bit more with this study. So I'll go through this figure slowly so I can describe you this. Next slide. So our hypothesis is that if we use a central SBP target instead of a brachial cuff SBP target in patients with advanced CKD, it would be possible to do so, and it will result in lower aortic stiffness. So our aim was to assess the feasibility and efficacy of targeting a central BP target instead of a brachial BP target. And ultimately, we would like to justify a large-scale trial aimed at showing that we can improve major adverse cardiovascular events, kidney outcomes, but also PROMs. Next slide. So this is a pragmatic trial. So it's aimed to be simple. So we don't have a lot of inclusion-exclusion criteria, and most of them are really aimed to identify patients in which we would want to change the blood pressure pills. So it's really adults with stage 4 or 5 CKD with an office brachial cuff SBP between 120 and 160. So why these numbers? It's, well, for two things. One, it's the range where the central and the brachial cuff diverge the most, but it's also the range where we're most likely to change our treatment for the blood pressure. And it's a short trial, so we want to make sure that we do something during this short time. We're going to exclude patients who already have too many antihypertensive drugs, or whether the patients or the attending doctor doesn't want to change the blood pressure pills for whatever the reason, and also those who had like recent events that maybe would introduce bias in our evaluation. But really, it's really an easy study population. Next slide. So our intervention is to compare a central systolic blood pressure target below 130, which is the usual definition of central hypertension, and a brachial cuff systolic blood pressure target below 130, which is standard of care, but I acknowledge that there's a few guidelines that change the SBP target, but let's say it's a commonly used target for this population. So again, it's a pragmatic trial. So the attending physician will have the choice of antihypertensive drugs, will have the choice to meet this target or not, will have the choice to aim for lower or not. And all the other aspects of CKD management will be, as usual, decided by the attending physician. And we've also wanted a minimal number of tests to assess outcomes. And this is where the patient partners were really helpful with the study, because when we start, we want to assess so many things, but then we get the patient partner who say, well, I'm not interested in doing ABPMs or this and that. So we had to cut down, and this is a good thing, I think, in the end. And we're going to minimize the number of study visits. And the device that will be used, it's a watch BP device. So really, this device can be used for regular brachial cuff measurements, and it has an algorithm that you can buy, which is inside the device that allows the estimation of central BP. And what it does, it just keeps the cuff inflated for 20 to 30 seconds after the brachial cuff measurements, and then it derives the central BP. So it's really easy for the patients and easy for any person who want to measure blood pressure. And what's good is that we can mask the device, the readings on the device, and display them only on a laptop. So it's easy to blind the readings of this device. And we're going to use standardized AOBP, so we have really high quality measurements. Next slide, please. So we'll use an online one-to-one randomization stratified for center and CKD stage, and with random peer-muted blocks to make sure that we can't guess what the next patient would be. And everybody will be blinded, including the patient and the physician. The only patient who will not be, and that's the nurse or the research assistant, will measure the blood pressure because this person will need to report this reading to the attending physician. And what we'll do is the nurse will only report the systolic, diastolic, and heart rate according to the randomized group. So they'll either just give the central BP reading or just a brachial cuff BP reading on a standardized form. So this person will be aware of both measures, but will only give the right one for the randomization. Next slide. It's a 12-month trial. It's arranged around the regular visits of the patients. So we didn't want to make the patients come every month or so to get the BP target. We wanted to be as simple as possible, as pragmatic as possible. So the number of total visits will vary from patients to patients, probably likely be from every 2, 3, or 4 months. So the only mandatory visit will be at the end of the trial at 12 months just to assess the outcomes, but all the rest will be according to the attending physician. Next slide. So we have 2 primary outcomes. The first is a feasibility outcome, and we'll have predefined criteria, which is really aimed around, well, is it possible to do this study? Is it possible to enroll patients? What happens to the enrolled patients? Do they attend the end visit trial, the facility? Do they achieve the SBP target? But also we want to know what would have happened if we have chosen the other type of blood pressure. Let's say in the central BP group, what would have happened if we used the brachial BP target, or as opposite, to see if there would be a change in the decisions that we would have made if we would have used brachial cuff for everybody. And we want to evaluate therapeutic inertia, which is always a bit of a problem in these kind of studies, especially blood pressure studies in CKD patients. And we'll also have a primary efficacy outcome, which is the aortic stiffness measured by what we call carotid femoral pulse width velocity, which is really a standardized way to measure aortic stiffness. So we'll have a measure at study initiation and at the end of trial. Next slide. We also have a few other outcomes that we want to assess. It's really going to inform the safety of the intervention, but also if there's events that we need to look out for if ever we go to a large scale trial, and also some renal outcomes, meaning change in eGFR, albuminuria, and we want to see the change in the dosage of antihypertensive drugs and quality of life. Next slide. So our sample sizes, so we need 92 patients to see a difference of 1 meter per second change in carotid pulse width velocity, which is a clinically significant change. And if we add the 20% estimated dropout, we'll need 116 participants. And this is quite enough also to assess our feasibility outcomes. And we have 7 sites across Canada that will participate. So it's not going to be a too overwhelming rate of enrollment. So hopefully we'll end this by 24 months of enrollment. Next slide. So we'll start quite shortly. I think I'll have the first patients here at Psychic Care in about 3 weeks, if everything goes well. Other sites will follow hopefully shortly after. So most sites are in Quebec, so the ethics is done almost. And we have 1 site in Ottawa and 1 in Regina. And hopefully by spring 2024, I have some results to show you guys. Next slide. So what is the potential impact? Well, it's the first study to assess this new way of measuring blood pressure in advanced CKD patients. There's really just 1 other RCT that evaluated the central BP target, which was done a few years ago with a device that is not as good to estimate aortic blood pressure, and it was still a positive trial. So we'll see if this can translate in the advanced CKD population, but also with a more accurate device, which is called a type 2 device. And hopefully with this, we can move forward to a large scale trial, which we would hope would show that there's a way to improve outcomes in patients and to improve problems also. And really, if this is really a simple maneuver that could really fundamentally change how we manage blood pressure in this population. So that's a bit it for this presentation. You can go to the next slide and I'll be happy to take any questions.
That's great, Remi. Thanks. Really interesting. And it's funny, something that you sort of just take for granted, which is blood pressure in your assessment of patients. It's really nice to, potentially see something of value that might be very, very different and actually might bring some, real world important consequences in terms of the outcomes that you're studying. I'm going to open it up for questions, and I do see that David has his hand up. David, go ahead.
Hey, Remi, great presentation. Really important topic that's clinically relevant. I have two questions. The first one is that systolic blood pressure target of 130 and it changing to now 120 based on SPRINT and select patient population. How are you going to handle that, as well as potential case mix variation of diabetics or proteinuria kidney disease, et cetera? That's the first question.
Yeah, so I think the 120 is very controversial. I think the data that supports it in this CKD 4-5 population is not there. It's an extrapolation of a much healthier population with the SPRINT CKD population. So I think this is controversial, and there's been some editorials here and there that show that we shouldn't do the below 120 in this population. I think for certain patients it might be appropriate, but maybe not all. So the change of when I first started this trial, changed my choice of target a few times during the reduction. And I was hoping that KD go and all that would aim for below 130, because that's what I would have done with the available data, but that's not the case. So how I'll address this is, while the physician it's permitted to aim lower. There's nothing against that. You can aim below 120 if you think that's what's the most appropriate for a patient. I personally don't believe that, but I know some people do. So again, how we will address that afterwards, it's already going to be difficult to see what happens with because the brachial cuff in the central blood pressure group will be lower than the brachial cuff pressure in the brachial cuff group. So it's going to be a bit difficult to address how this affects, let's say, the aortic stiffness. And then if we add some patients who have a lower blood pressure target, so much lower blood pressure, it may be a bit difficult. So this is something that I'm currently thinking about. Not too sure what's the correct response. But again, I'm not too sure that lots of patients will have much lower blood pressure than the target I'm suggesting.
It kind of dovetails to my next question. So I was surprised to see about the precision of the device you selected. Like there was a standard deviation of 10. I think it was only in 10 patient advanced CKD. So do you have any idea of like who the patients are that are systematically lower, that if you are aiming for 120, 130, that they're actually sitting lower than that? And those are the people that generally will have symptoms of orthostatic hypotension, stuff like that. Is there any, or is that something that you're going to be looking for in your pilot as well, for like, or what's the plan for that?
Yeah, so I mean, we're planning to, at the end of all this, check what's the difference between the brachial cuff and the central blood pressure, and if there's a way to predict this difference, and in the central CKD study, but also in the validate CKD study, which is the invasive BP study, because really we don't know. And I did a study on 500 patients with invasive BP readings. It wasn't aimed specifically at enrolling CKD patients, and there really wasn't a way to non-invasively predict the difference between the brachial cuff and the central BP. And it's dependent on many things. So yes, there's the systolic blood pressure amplification, but there's also height. So we were very surprised to see that females have more underestimation of the aortic SBP than males, mostly because of height difference. There's so many factors that goes into this difference, and it's something that we take care, we don't really know, and we never consider when we have a brachial cuff BP reading. We always assume that when it's measured in the proper way, in the standardized way, we're going to get an accurate device. We're going to get an accurate reading, which is true that we're going to get an accurate reading compared to the manual method, which is not as good. It's not the gold standard. So there's a few groups and a few consortiums that are trying to prove invasive BP data to try to find a way to see what's associated with this difference in the central and the brachial, to see if there's a way to develop some algorithms or some conversion factors. But for now, there's nothing that really tells us that.
Thanks.
It's great. Thank you, Remi. I do have a question. I'm just cognizant of time, so I might put my question in the chat to you just so you can keep an eye out for it, just around how you're going to capture inertia. So I'll put that sort of in the chat. But thanks for really a great presentation, and good luck to the initial study, and then hopefully you have the data for the big trial that will follow. So fantastic.
Yeah, thanks.
So for the last presentation today, we're going to move on to Dr. Dylan MacKay. Now, this is a pre-recorded talk. Dylan was hoping to join us, but unfortunately, I believe he's away right now in Europe, I want to say. So he'll be doing this as a pre-recorded talk. So Dylan has a PhD in human nutritional sciences and is an assistant professor at the University of Manitoba. He's a clinical trialist with an interest in trials involving nutritional interventions in those with type 1 and type 2 diabetes, chronic kidney disease, obesity, postprandial glucose metabolism as well. Now, I mentioned he's not here today. I am a co-investigator on this particular proposal and a pilot as well that's related to it. So I can try my best to answer some questions with perhaps some limited success. So without further ado, here's Dylan. I'll just quickly add to you that this was endorsed by the Scientific Operations Committee in 2021. Go ahead.
Hi, my name is Dylan MacKay, and I really appreciate the opportunity to present to the CNTN about some of the nutritional interventions we're exploring right now for metabolic acidosis and chronic kidney disease, and some of the trials we've designed and we're hoping to complete to evaluate some of those interventions. I'd like to start by acknowledging that the University of Manitoba is located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and the homeland of the Métis Nation, and that we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I'm not currently located in Manitoba, and I would love to be presenting in person at the research symposium, but I'm currently in Germany visiting my grandparents for the first time in 3 years. I'd just like to start with some disclosures. I have research ongoing that's funded by the Weston Family Foundation and Norwest Co-op, and the Kidney Foundation of Canada, Canadian Institute of Health Research, and I have some ongoing research with PepsiCo. The trials that I'm going to be talking about include partnering with Save On Foods and Food Fair grocery stores, and they're committing paid and in-kind products and services to undertake this research, and wouldn't really be possible without them to do this kind of food delivery and fruit and vegetable intervention. Just as a background, metabolic acidosis and chronic kidney disease occurs in some individuals when their kidneys are no longer able to excrete the dietary acid load that they have, and it's the ability to excrete the dietary acid decreases as kidney function declines. And it's estimated that upwards of 300,000 plus Canadians with chronic kidney disease may have some level of metabolic acidosis. And metabolic acidosis is associated with increased insulin resistance, an accelerated loss of lean mass, and obviously it's also associated with other negative outcomes like increased cardiovascular disease risk, increased risk of frailty, and increased risk of mortality. So oral alkaline therapy, mostly sodium bicarbonate, is the primary treatment for metabolic acidosis in patients with CKD right now in Canada. Although there's good evidence that it's undertreated, and there's definitely evidence that the sodium bicarbonate treatment is poorly tolerated. The recent bicarb study in the UK was a large multi-center randomized controlled trial looking at sodium bicarbonate for metabolic acidosis, and they didn't show any improvement in physical or renal function, unfortunately, with the sodium bicarbonate, and they also did some economic evaluation that suggested that the sodium bicarbonate was indeed cost effective, even though it's quite a low cost intervention. There's suggestion that the compliance in the sodium bicarbonate was likely lower than expected, and as well, upwards of 20% of the people in oral sodium bicarbonate withdrew from that arm on their own request. So it's patients report that it's a lot of gastrointestinal side effects with the oral sodium bicarbonate. Data in Manitoba from Dr. Tangri's group supports this. Upwards of 68% of the people who are prescribed oral alkali therapy for metabolic acidosis in Manitoba discontinue the therapy within 1 year. One alternative to oral sodium bicarbonate that we're really interested in exploring for metabolic acidosis and CKD is actually intervening on the dietary acid load by providing base-producing fruits and vegetables. Essentially, the kidneys have to eliminate between 50 to 100 milliequivalents of acid every day, and the largest contributor to that is the dietary acid-base balance. There are various equations that can estimate the amount of acid or base produced by a food, if you add base, or base-producing foods, then you reduce the overall dietary acid contribution that the kidneys have to deal with. Dietary potential renal acid load is calculated using an equation. It's based on protein, phosphorus, potassium, magnesium, and calcium content. And using this equation, we've just designed nutritional intervention where we provide people with a 30 to 40 milliequivalent negative PRAL or a bicarbonate equivalent dose. And so this is an example of minus 30 milliequivalents of fruit and vegetable. It's a medium apple, 100 grams of carrots, 100 grams of celery, and half a cup of tomato juice. So this fruit and vegetable intervention has been used in 3 or 4 trials conducted by Garaya and Wesson in Texas, in lower income neighborhoods in Houston, Texas. And interestingly, what they were able to show is that it's pretty much equivalent to the oral sodium bicarbonate. And in the earlier trials, when they tried to just give people enough fruit and vegetables for that one participant, it wouldn't work until they started providing enough of the fruits and vegetables for the participant to be able to sort of share their required dose with their family to have an impact. What they did is they recruited individuals in this current trial who just had baseline bicarbonate of 23. And so they could have a usual care control, and relative to the usual care control over 5 years, the sodium bicarbonate in the fruit and vegetables actually maintained higher serum bicarbonate levels, as well as it slowed kidney function decline according to EGFR, and the fruit and vegetable and sodium bicarbonate were equivalent. Based on our data for compliance, this trial likely had much higher compliance and continuation of the sodium bicarbonate that's seen in the Canadian population. And the intervention, the fruits and vegetables, were delivered through church groups to the participants and their families. The question is, can we adapt and deliver an intervention where people consume base-producing fruits and vegetables to treat metabolic acidosis in Canada? And so the Garaya trial selected individuals who didn't have very, very low serum bicarbonate levels. They didn't have cardiovascular disease. They didn't have elevated potassium, and they didn't have diabetes. And so if you took the populations from those trials, you would actually be excluding most of the people who have metabolic acidosis and CKD in Canada. Not to mention the fact that there's a very different food and healthcare system between Houston, Texas, and across Canada. So that's sort of where we're doing research. We designed the RAVe-DKD trial, which is the title of this presentation. It was a plan to look at the efficacy of fruit and vegetables delivery, lowering dietary acid load, and preserving kidney function in diabetic kidney disease specifically. That was sort of because that was the large grant we were applying for, was focused on diabetic kidney disease. We're interested in whether it works in people with diabetic kidney disease or other chronic kidney diseases. And we have recruited a great network of 13 nephrology centers across Canada, pretty much coast to coast, from Nova Scotia to BC, unfortunately not Newfoundland, where I'm originally from. And we've designed a multi-center randomized control trial, and we figure based on our power calculation, we need about close to 200 participants likely more if we want to power it for people with diabetic kidney disease and without separately within the trial. But unfortunately, we were not successful in our first application, and so we're working to support and make the next Pan-Canadian trial application stronger. And to do this, we were lucky enough to get funding through the CIHR projects for a feasibility trial. So that's our redacted trial, reducing dietary acid with fruit and vegetables versus oral alkali. And we're hoping that this feasibility trial will make our application for the Pan-Canadian trial that much better. So in this trial, it's a two-center randomized controlled feasibility trial. We're going to have one center in Winnipeg led by Dr. Tangri and one center in Halifax led by Dr. Tennankore. We're looking to recruit 40 individuals, 20 at each site, and just looking at feasibility basically around the fruit and vegetable intervention to help us design the larger trial. So, recruitment rates and retention, follow-up, and also some average adherence. So, how much can we get people to change their dietary acid load by delivering the fruits and vegetables to people's houses? We're also going to measure some safety outcomes and make sure that the intervention is safe in surrounding. So we'll be monitoring for hyperkalemia and elevated sodium bicarbonate, as well as some other safety factors. So we've finalized the redacted food intervention for the trial. We're actually hoping to start in Winnipeg very shortly and in Halifax soon thereafter. And the whole intervention is going to basically be focused around weekly fruit and vegetable grocery deliveries that we'll be able to conduct with our partner grocery stores. So in Winnipeg, Save On Foods is going to be doing the grocery logistics and ordering. We'll be using their e-commerce system to prepare boxes for every participant, and they're going to get delivered to their houses on a weekly basis. And then that's nice because it's existing infrastructure and we can show scalability for the Pan-Canadian trial quite easily. How can we deliver these interventions? This also shows that if this became an intervention that we use to treat metabolic acidosis and chronic kidney disease, we can show that it's feasible because this infrastructure in the grocery stores already exists. It also helps. We have a health economist who's going to help do health economics assessment of the fruit and vegetables and figure out what the cost of a year of the fruit and vegetable delivery is compared to the sodium bicarbonate. So the fruit and vegetables will be delivered by the grocery stores, and we're going to be delivering enough fruits and vegetables so that every member of the household that the participant is in gets the required dose, so that we don't end up with any dilution of effect via sharing, which is seen in the studies in Texas. And so everybody in the family of the participant has the potential to benefit through increasing their fruit and vegetable intake. And so, the participants are going to meet with a study dietitian at the beginning, and they're going to be explained how to measure the fruit and vegetable dose per day. We've converted the negative milliequivalents into a point system. So essentially that's a picture of 30 points for points in low acid fruits and vegetables. Negative 1 milliequivalent is a single point, and the participants are going to be told to consume 30 to 40 points per day starting off, and it might get adjusted a little bit based on serum bicarbonate measurements at 1 month and 3 months, but and be adjusted up or down. And we'll have dietitian time to assist the participants in making those adjustments. We're also delivering food scales and measuring cups with the nutritional intervention. And in our nutritional instructions, we have tables for every food that will show up in the boxes, and how much weight per dose. So 180 grams of beets is 20 point dose. So that would be equivalent to a negative 20 milliequivalents of beets. And so, we also have examples in the handouts and in the training where they will be shown how to put together daily requirements. So this is someone's full daily requirement using 4 different foods. So 133 grams of cooked mashed yams is 10 points. 136 grams of carrots is 10 points. 266 grams of frozen mixed berries is 5 points, and 73 grams of banana is 5 points. So while we were writing all the grants for the RAVe-DKD trial and for the redacted trial, which we finally got funded, we got a lot of comments about potassium. We're going to be providing people, giving people fruits and vegetables delivered to their home, and a lot of those fruits and vegetables that are sodium bicarbonate equivalent fruits and vegetables are also high in potassium. So what about hyperkalemia risk, and what about the potassium was something that we received a lot of feedback on from by the reviewers. In fact, in the redacted trial, we had to reduce the level of potassium that we would allow in, so people had to have lower potassium to get into the feasibility trial before it got to the fundable level. And we wanted to address that specifically because, looking at the trial literature, there's not a lot of clinical trial evidence that dietary potassium levels strongly influence serum potassium. That we thought that be something we could address directly with a trial, and then it would support our pan-Canadian intervention with the fruits and vegetables for metabolic acidosis. So in particular, we're interested in the dietary potassium from fruits and vegetables because that's what we're going to use for our intervention. The potassium in fruits and vegetables may not be the same as elemental potassium in the diet, and its impact on serum potassium may be different because a lot of fruits and vegetables tend to have things like fiber and carbohydrates, which can influence insulin levels, which may influence where the potassium ends up, intracellularly versus in the serum. And so we were able to design a crossover trial, and that we've received funding from the Kidney Foundation of Canada, and we're going to specifically look at dietary potassium liberalization using fruits and vegetables. And so in this crossover trial, we're going to use grocery store delivery again, and one of the intervention periods, participants are going to get high potassium or higher potassium fruits and vegetables in their delivery box, and in the other intervention, which we randomized into a crossover with, will be sort of standard dietary potassium restriction. These will be lower potassium fruits and vegetables, and they'll be instructed during the liberalized potassium intervention to consume around 1,500 milligrams of potassium a day from fruits and vegetables in their delivery box, targeting a daily intake of around 3,500. And in the standard restricted potassium, they're going to be incorporating about 500 milligrams of potassium a day from the box foods, and the dietary potassium intake of less than 2,000 milligrams. And so I really wanted to thank again Dr. Tennankore for the opportunity to talk about these trials that we're doing, and it's just the only reason I'm able to take part in this is because of all the fantastic collaborators I have, on these two projects in particular. Dr. Leah Cahill, who's at Dalhousie, and Dr. Tennankore. Dr. David Collister is involved in these projects as well. And Dr. Rebecca Mollard, who is essentially the other half of all of my research, and Dr. Tangri in Winnipeg. As well as Dr. Robert Balcha, our statistician, Dr. Jennifer Prodiger, who's leading a lot of the qualitative work that we're incorporating in these trials around, sex and gender, and around, the EDI and the potential qualitative impacts of providing whole families with fruits and vegetables rather than just individuals, and the burden potentially of food preparation that we're putting on the families. We want to make sure that we're removing as many barriers as possible in our interventions. So if it's too difficult for people to prepare the fruits and vegetables as delivered from the grocery stores, we have the potential to potentially modify and provide ready-to-eat foods that also have bicarbonate equivalents. And finally, Dr. Bodan Lahovy at MSVU in Halifax, and he's really going to be helping us do the fruit and vegetable delivery there, as well as our patient partners, Dr. Sharon Mosick and Dave Reed, that are involved in all the steps of the design of these interventions, including the design of our nutritional handouts and things like that. And I'd really love to be taking part in the live questions and answers, but I can't. And fortunately, Dr. Tennankore and I think Dr. Tangri will be in attendance, so you can direct all the questions to them. And thank you very much for listening.
I think it's a really interesting area that Dylan is embarking on, which is looking at ways to maybe address this sort of classic teaching about all the need for dietary restriction around a variety of different foods versus the potential impact that that might have on patients and their quality of life, and maybe thinking about different ways to address things directly with food. And I can say that there are a lot of other researchers coming out of Canada who are kind of taking a principal interest in how to modify diets to maybe potentially be advantageous for patients. And just to close things, I think Hans, if you're there, Hans, I'll let you sort of take it away to close out the meeting. We're actually a little bit early, which is great.
I thank you for coming. We would like to hear any comments that you might have about this. In fact, if you can check out our website, you will find that there will be in a few days a post-symposium survey, and we would hope that you could fill it out, because we want to make these events as interesting and topical as possible. And feedback is obviously the only way that we can actually assure that we can be on the right track and making whatever improvements our audience would like to see. Anyway, I wish you all a good day. I hope it's all as nice and warm and sunny as it is in, well, I say downtown, but almost downtown Kingston. And farewell. Hope to see you all next time.
Thanks a lot. Take care, everyone.